Hi friends, this video shows the management of a shining, a mature and intumescent cataract, which is quite commonly seen in our Indian scenario. So I start the case by making a side port, staining the capsule with trypan blue dye and injecting a high viscosity OVD through it. And then I create a very small nick in the center of the anterior capsule to allow the fluid to escape. This reduces the intralenticular pressure and also reduces the risk of rhexis runoff. However, you still have to be very careful, and what I like to do is to make a primary rhexis first, which is of a smaller size. I usually aim at a size of about 4.5 millimeters or so. At this point, it is important to make sure that the anterior capsule is always flattened using the cohesive viscoelastic. If you are able to complete the rhexis in one go, well and good. However, sometimes you may have to enter through the main port and use a rhexis forceps to complete the CCC as shown in this case. So you can always use the rhexis forceps through either the main port or the side port depending upon the ease of accessibility. The rhexis is now complete, and make sure that you don't do too much of a hydro. Usually these mature intumescent cataracts do not require much of a hydro dissection. For phacoemulsification, direct chopping techniques are preferred over trenching techniques such as the stop and chop and divide and conquer techniques. These are known to cause more stress on the zonules and would also lead to higher consumption of the ultrasound phaco energy, which could potentially lead to damage of the endothelium and delayed visual recovery due to postoperative edema. Now, when you are separating the fragment, it is okay to stay a little superficial. Just hold the fragment with the phaco probe using a slightly higher vacuum setting and place your chopper slightly deeper into the groove, and then use it to separate the fragment very gently without causing much of a lateral separation. As the zonules in these mature and intumescent cataracts tend to be weaker compared to the routine ones, and using excessive lateral forces can lead to intraoperative zonular dialysis, which could complicate the case. Now, since this nucleus is on the denser side, I am again injecting OVD for endothelial protection, and followed by this, the remaining fragments are easily emulsified. For the irrigation and aspiration, I generally use a coaxial cannula. However, in these cases where the rhexis is on the smaller side, I generally like to use a bimanual IA system, as the cortical cleanup can be performed more thoroughly using this. Once this is done, now the intraocular lens can be implanted into the capsular bag. However, this is not the end of the case. You need to perform a secondary rhexis to enlarge the size of the CCC to prevent postoperative capsular phimosis, which can lead to late tilt or decentration of the IOL. This can be done from the side port using a microcapsular forceps as shown. Finally, the OVD is evacuated from the anterior chamber, and this brings us to the end of this case. Thank you for watching.